Hi, good morning, and welcome to all of you on this rainy day, which is good for the spring flowers. We're really delighted to kick off a program that Amy Rosenberg and I have been talking about, which is wanting to highlight all of the wonderful work we're doing in quality and patient safety across the department. And as you've heard me say before, there's really no place in the department where we're not doing great quality work. And Amy and I felt it was important on a biannual basis to highlight some of the work that's being done by our faculty, by our trainees, all in the interest of improving outcomes for patients. Amy won't want me to spend a lot of time talking about her, but just to briefly remind you who she is. She's such a stalwart member of the department and such an important leader in the department. Amy was valedictorian of her high school class at Framingham South High School, and then completed her BS in biology at Tufts, and then her medical degree at Sackler, and has spent almost her entire career with us, first doing her residency and internship at St. Luke's and Roosevelt, and then completed her fellowship in infectious diseases at Memorial Sloan Cancer Center. And early in her career, and importantly, I think, headed up the TB unit at Westchester County Department of Public Health. But as I say, it's been with us for many years and currently is an associate chair in the department, overseeing quality as well as faculty affairs. She's an associate CMO for both of our hospitals, and associate professor in the Department of Medicine at the Icahn School of Medicine at Mount Sinai. Amy is a wonderful champion of quality and is extremely knowledgeable and is a great supporter to the department and a great mentor to our faculty and our trainees interested in advancing quality. And we're delighted to have this first roundtable today.
Okay, good morning. Thank you for that kind introduction. So what I'm going to do today is I'm going to talk about the structure and components of our QI program here. And in the future, when we have these grand rounds on quality, I'm going to put in an educational piece that I'm going to leave out today just for a lack of time. And then we're going to switch to Dr. Tina Park, who's going to talk to us about the GI QI projects, and then Dr. Kareem El Hashim, who's going to talk to us about the nephrology QI projects. So I put this slide up here, not for you to look at the whole thing, but just to show you that we do have an integrated quality program across all of our sites in the Mount Sinai Health System. And this program is led by Dr. Beth Rauscher, who is the Vice Chair for Quality and Clinical Affairs over at Mount Sinai. And she comes to our quality meetings, and I and my counterpart at Beth Israel go to the quality meetings at Mount Sinai Hospital. And it's not really just a cliche, but we really do bring best practices across the system. So what are our priorities for our quality program? So if you look on the left, we definitely react to events that happen. So, and we have for many years. So when there's an adverse event, we try and find out what happened, and we come up with plans of correction to make sure it doesn't happen again. We review 100% of our mortalities, and of course, we have a very robust hospital infection control program, and we in the Department of Medicine definitely take part in that. If you look at the middle column of this slide, you see that we have some regulatory issues that we have to address. And the one that's been addressed for many, many years, of course, is the Joint Commission. And years ago, the Joint Commission used to just survey the environment and deals a lot with nurses. But these days, we really have to be involved in these surveys. And years ago, it used to be a few months before they came, the hospital would sort of rally and get everybody to learn about the things that we need to know. But now we really have an ongoing process. And some of the things that we keep telling you are things that you will hear again and again because Joint Commission wants them, and they really do make us to be a safer hospital. Now, as it turns out, Joint Commission, we expect to be coming here in a couple of months, either the end of June and early July. So we will be repeating over and over again some of the things that we think will make our hospital safer and that Joint Commission might be looking for. So what happened about 10 to 15 years ago was that we started to get all these pay-for-performance programs that were developed by different entities, mostly the federal government. And these are some of the programs that I'll be talking about in upcoming grand rounds. So value-based purchasing and some of the readmissions programs, healthcare acquired infections, and CMS even has these star rating programs, and they rate dialysis centers from 1 to 5 stars. They rate hospitals from 1 to 5 stars. So again, these are some things that you'll be learning more about as these grand rounds progress. On the right is really where we want to be and where we've been going, which is being proactive in our priorities. So today you'll be hearing about some of the divisional projects, and the divisional projects are obviously very important because the people on the ground are really the ones who know what needs to be looked at and improved upon and are able to do it themselves. So you'll be hearing about those. A few weeks ago, you heard from Dr. Grace Farris about some of the high value care projects that her division is doing, and the Choosing Wisely campaign. And just a couple of others that I have on the slide. We obviously have a clinical documentation program, and again, more on the other programs that I've listed to come. So we have a Department of Medicine Quality Council that meets monthly and that I chair. We have our divisional quality champions who attend that, plus cardiology, a residency program, the IAM, which is the HIV program. Hospital QI comes, and our chiefs come when they can. So our divisions report out twice a year, and each division is responsible for thinking up, completing, and presenting 2 to 3 QI projects. We work very closely with the hospital, with Eva Johansson, who's the Vice President for Quality, and we review our M&M data, and we educate at this meeting as well. So who are our quality champions? Well, you're going to meet 2 today. And you're going to be meeting a few when we meet again in about 6 months for our next in our series. So I'll just go through them quickly. Navia Casely-Hayford is our Gen Med, our ambulatory quality champion. Shanthari Shenoy, whose picture you saw when Dr. Grace Farris was here giving her presentation from Hospital Medicine at MSW. Milu Kojic from ID, and Janet Shapiro from Pulmonary Critical Care. Now, we've lost a few of our quality champions, but we are actively recruiting for the endocrine, hospital medicine at St. Luke's, and our rheumatology divisions. So we do, as I said, review 100% of our mortalities, and the Division of Hospital Medicine currently does that for us. And we now use an electronic mortality tool, which was actually spearheaded by Dr. Beth Rauscher, who had it in her previous hospital with our input. And it's very nice to have an electronic tool because you can use the data and create reports. And the system is actually creating an electronic tool, which is based on our own tool. And lastly, I wanted to tell you about our M&M meetings. So hospital medicine at each site has monthly meetings, and they review the mortalities in which there's a quality concern after initial review by one of the hospitalists. So the hospitals review the charts. If there's no quality concern, that's fine, just gets reported. But if there is a quality concern, it goes to this the hospital mortality meeting where the hospitalists go, and it's discussed, and a consensus opinion is determined at that meeting. So we did have subspecialists at that meeting, but they seem to have fallen off. So if I have any volunteers who would like to join this meeting and help us out, please come talk to me afterwards or shoot me an email. House staff has their own M&M, and this is for the attendings who don't know. It meets every other week, and there are PowerPoint presentations by a PGY3. And what's nice about their M&M is that they learn how to use QI tools. So fishbone diagrams and root cause analyses are discussed by the house staff. And also, if you don't know, the chiefs send out a daily email which has the teaching points of the day, and it includes the M&M teaching points. So, the chiefs, and I have to point out Dr. Janet Shapiro, help the house staff with those M&Ms. Okay, so that's basically an overview, a quick overview of our program. And again, I'm going to sort of fill in some of the spaces as we go on in these lectures. And now I'd like to turn to our QI projects, and I'd like to introduce Dr. Tina Park, who's an assistant professor of medicine. She did her residency at Brown and her GI fellowship and was chief fellow at UMass. Then she went on to do an advanced endoscopy fellowship at Columbia, where she learned endoscopic ultrasound, ERCP, and other advanced procedures. And I just want to say on a personal note that I really enjoy working with Dr. Park because she's very motivated, she's very driven with her QI projects, and she is so hardworking. She spent hours and hours by herself reviewing charts to get her own data. So, so Dr. Park will show us what you've accomplished.
Hi, good morning. Thank you, Amy, for that kind introduction. And thank you for the invitation today to talk about our QI project from the GI division. Our projects are focused on screening colonoscopies, and we'll be talking a little bit about bowel prep quality and adenoma detection rates today. So the first project is bowel prep quality for screening colonoscopy. As you all know, colorectal cancer is the third most common cancer in the US, and there are 135,000 cases in 2017 that accounted for 8% of all new cancer cases. And also in 2017, there were 50,000 deaths from colorectal cancer, and that accounted for 8.4% death from all cancers. As you can see from this graph here, both the incidence and the mortality rate from colorectal cancer has been decreasing steadily, really since the mid-1980s. The graph starts here at 1992. And if you look at this graph, the colorectal cancer is this blue line right here. And compared to all the other cancers, it's the only one that's been steadily decreasing in terms of incidence in the past 15 years. And that really speaks to the effectiveness of screening colonoscopies, where we look for polyps and remove them at early stages so that they don't have the chance to grow into large polyps or cancer down the line. So in order for us to really accomplish good effective screening colonoscopies, having a good bowel prep is very important. Suboptimal bowel prep may hinder our ability to detect polyps, especially small or flat polyps, thereby decreasing the effectiveness of screening colonoscopy. In 2015, both ASG and ACG task force updated our quality indicators for various GI procedures, including colonoscopies. One of them was the percentage of adequate bowel prep or inadequate bowel prep. And they suggest that the percentage of screening colonoscopies with inadequate bowel prep that would essentially require early interval repeat colonoscopy less than 1 year to be below 15%. In other words, the target adequate bowel prep for us will be greater than 85%. And we defined adequate bowel prep by adequate bowel prep essentially means quality of bowel prep that allows us to detect polyps 5 millimeters or greater in size. So what we did here is to do a retrospective chart review of all patients at St. Luke's and West who underwent screening colonoscopies from January 2016 to November of 2017. Provation is a software that we use currently to document our procedures. So we use Provation to obtain our number of screening colonoscopies, and we use the same software to look for quality of bowel prep documented in those screening colonoscopies. And bowel prep was considered to be adequate if the quality was described as excellent, good, adequate, or satisfactory. And the bowel prep was considered to be inadequate if the quality of bowel prep was documented as fair, poor, inadequate, or unsatisfactory. So in 2016, we had 872 patients, about half women, half men. Average age was about 60. Majority of these patients took GoLightly prep, and they were done in outpatient setting. And our rate of adequate bowel prep in 2016 was 72%, which is below goal. Our target was 85. However, prior to 2016, we hadn't been following the adequate bowel prep rates strictly and really have not implemented any interventions to correct that. So I saw this as more of our baseline rate. So what are some of the problems that may be contributing to inadequate bowel preps? One was that we really didn't have the adequate resources to educate patients. We didn't have coordinators, schedulers, or medical assistants who can really review prep instructions or diet instructions with patients. So the faculty or the fellows did not always have adequate time to spend with their patients reviewing the prep process. We also didn't have printed instructions consistently available to us, and all of these things affected our patient compliance. So these are the interventions that we implemented in late 2016, early 2017. We discussed the problem at faculty meetings numerous times. We implemented a split dose protocol, which has shown to improve prep quality in research data. And we also reformatted our prep instruction sheet and had them readily available both at the GI clinic and faculty practice. We hire staff and now have support to educate patients in addition to our office visits. So following the GI clinic visit, there's a nurse who goes over the prep instructions with the patients. And same goes for our office visits. There's medical coordinators and assistants who can also review the bowel prep process with the patients. So in 2017, we had 1,279 patients who underwent screening colonoscopies, and the patient characteristics were very similar to 2016. And our adequate bowel prep quality did improve from 72% in 2016 to 78% in 2017. Although that's still below goal, you can see here that our trend has been increasing, and our preliminary data so far in 2018 looks very promising. Our adequate rate was 87%. However, what we're finding is that patient compliance still is a big factor in all this. So they are educated and they're knowledgeable of what to do the day before the colonoscopy, but they just have a very difficult time taking the entire bowel prep, which is a gallon, and fasting the entire day before the colonoscopy. So we still have to encourage patients to be compliant. And there's also a pocket of patients here that we don't really get a face time before the procedures. These are direct referral patients from PCPs who just come in for screening colonoscopies. So we have to make sure that we have a way to reach them and mail instructions so that they are adequately educated. Our second project, which is adenoma detection rate. So ADR is a frequency of adenomas detected in asymptomatic patients undergoing screening colonoscopy. And the same society's ASG and ACG recommends that our rates to be greater than or equal to 25% overall, and greater than 30% for men, and greater than 20% for women. We know from research data that decrease in ADR will reduce both in incidence and death rate from colorectal cancer. And we also know that patients who undergo colonoscopies by physicians with low ADR are at increased risk for developing post-colonoscopy cancer. So what we did also is to retrospectively chart review our patients from January 2016 to November of 2017. We used the same Provation software to obtain our number of screening colonoscopies. And we used PRISM to verify adenoma polyps found during those colonoscopies. So the way we calculated our ADR is number of colonoscopy where adenoma was found over total number of screening colonoscopy. So in 2016, our ADR was 32%, which is above target of 25%. And we met goal both for men and women. In 2017, sort of similar data, our ADR rate was 30%, slightly below compared to 2016 data, but still above goal for both men and women. And our preliminary data in 2018 is somewhat similar at 31%. So we've been fairly consistent on ADR. So what are some of the potential problems that may contribute to low ADR? There are many, so I try to organize them by different factors here. So there are physician-related factors, equipment-related factors, and patient-related factors. So we have to really spend the time and inspect each fold to look for these polyps. And we have to pay a lot of attention to the right colon. The incidence of the colorectal cancer from right colon is increasing, and there are cell-ulcerated adenoma polyps. They look just like hyperplastic polyps sometimes, and often are flat, subtle, and covered by mucus cap. So it's, again, very important to irrigate, inspect, and look for these polyps. Equipment is also very important. So having high definition monitors, the latest scopes with good optical resolution will help us detect these small polyps. Our older version of the scopes that we used to use did not have a water irrigation channel, which was a big problem. So each time we wanted to irrigate an area, that clogged up our working channel. It's very cumbersome. So again, having the later version of scopes that has a water channel will be very important in irrigating and inspecting for polyps. And lastly, patient-related factors will be inadequate bowel prep, which we talked about already, abnormal anatomy from prior surgeries, or just the characteristics of polyps. So in this picture, it's fairly obvious to everyone where the polyp is, but you can see here, this is a picture of the cecum and the right colon. It's covered somewhat by liquids and bubbles, and it's kind of hard to see that there is a polyp hiding behind this. This is actually a picture of one of my patients. When you irrigate this area with water, really inspect, there is somewhat of a subtle polyp right here, and this is a cell-ulcerated adenoma. So there are many things we can do to try to improve our ADR. One is physician education on importance of ADR, giving them feedback on their own individual ADR, and really maintaining adequate withdrawal time, which is the time that we spend from the cecum back to the rectum, looking for inspecting for polyps. There's data to show that physicians who spend more than 6 minutes withdrawing had much higher ADR rates than those who did not. So our target rate currently is to maintain a withdrawal time greater than 6 minutes. We talked a bit already about improving bowel prep quality, and we also upgraded our scopes in late 2016, early 2017 that does have high definition monitors and optical resolutions with water channel irrigation capability. And now there is a lot of development in device-assisted colonoscopy. And the point of this slide is just to show you that there are many different devices and scopes available now to try to improve ADR with somewhat mixed results. It seems that the endocap, this is a clear cap that goes in the distal end of our colonoscope, that would help us to expose between mucosal folds in the colon. It did not improve ADR compared to standard colonoscopy, but it did improve ADR in the right colon, which is also important. And it improved detection of flat adenomas. And this is an endocuff that has finger-like projections. Same idea, it will just help kind of open up the folds so that we can look between the folds better. And there are mixed data. Some data show that it did improve ADR, while others did not. So is it easy to increase ADR? The short answer is no. There are other data looking at this. Some groups have implemented mandatory withdrawal time of 7 minutes or greater. Their group had no difference in ADR rates post-intervention, while other groups show that having a mandatory withdrawal time of 8 minutes or greater did improve their ADR. Split dose bowel prep protocol did improve prep quality, but not necessarily the ADR. And physician education and feedback worked well in closely monitored setting when they got monthly feedback, but not so much when they got quarterly feedback, and not so much when they stopped the education altogether. So yes, prep quality, withdrawal time, and having the latest equipment is all important, but it comes down to lesion recognition, having good technical skills, and really the diligence and dedication to look for these polyps, especially in the right colon, even when the physicians know that they're not being monitored. Thank you for your time.
So we were going to take questions at the end, but we changed it around a little bit since we have plenty of time. So if anybody has any questions at this point, either for Dr. Park or for me.
I don't know if you can hear, but try to shout.
We'll repeat it.
We'll repeat the question for you.
Well, has anybody looked at patient factors that lead to poor bowel prep? For example, asking the patient what his average transit time is. In America, the average transit time is 3 to 7 days before they have bowel movements. So is there any correlation with poor prep and slow transit time? The other is whether or not you ask any dietary questions. Like, do we reduce some of the diet before the procedure to really reduce the amount that's there? So I wondered about that. And the last question is the ABR rates are following expectations, yet the bowel prep is below. How do you account for that difference? If your bowel prep is inadequate, how come your detection rate is so good? So I'm just curious about that.
Yeah, so the first question is, are there a group of population that just have slow transit, therefore increased risk of having an inadequate bowel prep? And the answer is yes. There are people with motility issues. There are people with diabetes or other medical issues that will result in the need for longer duration. So we do offer extended bowel prep for those patients. And if we have data from prior colonoscopies that they had a poor prep, then we automatically offer extended bowel prep for those special groups. The second question was, can you repeat the second question for one more time?
Actually, really the
Diet.
yeah,
Oh, that's correct. Okay, so you were wondering whether there's a special dietary changes that we recommend other than fasting. So we recommend avoiding fibrous, like vegetables or anything with roughage for 3 to 5 days prior, and then having a clear liquids only diet for 24 hours prior to colonoscopies. And the last question is, if our prep quality is suboptimal, why is our ADR rate high? And that really goes back to this slide right here. So if you irrigate, even if the bowel prep isn't the best, if you spend the time to clean and irrigate and look and inspect and really look between each folds, you will find polyps. And again, that just goes back to the physicians having the knowledge and skills of various types of polyps and having the skills to look for these polyps and having the adequate withdrawal time to look for them. There are people who look at the right colon twice. There are people who retroflex in the right colon, so they inspect forward view and both retroflex view. And data suggests that both of these modalities are equivalent and better than looking once. And there are people who do water exchange irrigations instead of insufflating. They just infuse with water going in. And some people think that that's better. The data is mixed on that as well. So there are various techniques that we use, but the simple answer is that if you are looking for polyps, you'll find them. It's just a matter of how hard you look for them.
In my life, I've done a lot of process mapping and also looking at time intervals for various parts of healthcare. And I'm curious, because one of the things I've learned from that is our perceptions of duration are very different than reality. So I'm just curious to know how you measure withdrawal time in a way that physicians can get on board with this.
Okay, so we track our withdrawal times by provation. So once we reach the right colon in the cecum, there is a time stamp that we can click. And once we withdraw the scope completely from the patient, there's another timestamp we click, and that will give us our withdrawal time. We don't necessarily get live feedback during the colonoscopy as to how much time we're spending. I think that's something that's variable between physicians. I think I tend to spend at least 2 minutes in the right colon, 2 minutes in the transverse, and 2 minutes in the left, maybe 2 additional minutes in the right colon. Other people may track their own time by either the clock or with the nursing staff. There are groups that I mentioned before who actually tracked their time, like mandatory time. They'll have a timer that clicks every 2 minutes. But as you saw here, sometimes that improved their ADR rates and other groups it did not. So yeah, to answer your question, there's no strict monitoring process currently, live tracking, but we are tracking our withdrawal times for each cases using Provation. Any questions from West? No.
I think she's just indicating no, there are no questions.
Okay.
Oh, okay. That's great. Thank you.
Okay. Thank you, Dr. Park. So next we have Dr. Kareem Al-Hashim, who is also an assistant professor of medicine, and you may also know him because he's a graduate of our internal medicine and our nephrology fellowship here. And when he graduated from his internal medicine residency, he won the honor of giving the Senior Lecturer of the Year in 2014, so you might remember him from that as well. He currently is the medical director of the Rogosin Institute Westside Dialysis Center. He has a lot of director titles. He's director of the Continuous Renal Replacement Therapy Program. He's a member of the Mount Sinai St. Luke's Hospital Root Cause Analysis Committee. So as you can see from all of his titles, he's very much involved in quality, not only for the hospital, but also for dialysis as well. And because of those responsibilities, we nominated him and he was accepted for the prestigious Greater New York Clinical Quality Fellowship Program, which he's currently enrolled in now. And for those people who don't know, it's, as I said, very prestigious, and it's a learning opportunity, and it ends with a capstone quality project, which Kareem is currently organizing now. And again, I have to say, as with Dr. Park, I really enjoy working with Dr. Al-Hashim because he's very enthusiastic about all of his work and really always wants to improve processes wherever he is. So you'll hear now about Dr. Al-Hashim's projects.
Good morning, everyone. So it's a pleasure to be here today to discuss the quality improvement efforts for the Division of Nephrology. So just a brief introduction about the Division of Nephrology for those who don't know. So we are 7 nephrologists, and we are training currently 2 fellows. The quality improvement efforts that we do feed into the Department of Medicine's quality effort, as Amy mentioned earlier. So I'm going to be talking about 3 of our completed projects, and then I'll touch upon 2 of our ongoing efforts. One of them is actually my capstone project for the fellowship. The first one was about improving the documentation of NSAID use in patients who are hospitalized whenever nephrology was consulted, either for acute kidney injury or for an opinion for patients with advanced chronic kidney disease, stage 4 or 5. So frequent use of NSAIDs, obviously, we know, especially in high-risk patients, is associated with a lot of acute kidney injury and even chronic kidney disease. And it has been estimated that 1 to 5% of all patients who use NSAIDs develop nephrotoxic events at some point. Since there's a very, very large number of patients taking NSAIDs annually, up to 70 million prescriptions per year, whether it's for arthritis or chronic pain, and more so 30 billion over-the-counter doses per year of NSAIDs. So that would translate to about 2.5 million patients experiencing a nephrotoxic event annually. A lot of times, physicians and patients would forget to even ask about NSAID use, since it's such a common drug and it can go unnoticed. So we looked at 100 consecutive consults between October 1st and December end of December of 2014, and so we did a chart review, and we saw that the rate of NSAID documentation was 54%. And the goal of this initiative was to improve the documentation of NSAID use. So by documenting that, we would actually prove that we asked about it, and also that would give us an opportunity to educate these patients who are at risk for nephrotoxic events to avoid using NSAIDs. So initially, the intervention was a weekly email reminder to both the faculty and the fellows. And since we have lots of residents rotating with us on the consult service, we also educated them, since they were in charge of doing a lot of times the initial consult. And then the data, we did pretty well throughout the year. The baseline, as I mentioned, was 54, and we set the target to be at about 65 or more. As you see, there was a little dip in July. Part of it was the start of incoming house staff. Also, we realized that it could be email fatigue or notification fatigue. So for that reason, we added a section in the template for the initial consult note. For example, past medical history, past surgical history. So we added also NSAID use as part of the template, and that helped us bring back up the rates throughout the year. So that was for the first one. The second one was improving the timeliness of permanent access placement in patients who were hospitalized, who were initiated on dialysis while they were in the hospital. So the population already was patients who are not necessarily very compliant with medical follow-up. So these end up in the hospital with whether known or unknown chronic kidney disease, and they end up starting on dialysis. We know that there are two kinds of accesses, the permanent accesses like AV fistulas and AV grafts, and then also the perm cath, which is a central venous catheter. Also, we know that AV fistulas and AV graft are superior in many, many aspects compared to permanent catheter-based dialysis. They have been shown to decrease morbidity and mortality among patients on hemodialysis. There's a subset of the population who actually, this is not necessarily true for them, but for the most part, this has been validated. And also, obviously, these accesses last longer and have a longer survivor rate. They have also a lower infection rate as compared to the permacath. And patients who have permanent accesses tend to be admitted less to the hospital. And more importantly, they also had a better health-related quality of life. So this actually initiative comes from a long history of initiatives from CMS and from the ESRD network that prone this idea and encouraged physicians to push for a permanent access right away. So in 2001, the rates of AV fistula use was pretty low. For incident dialysis patients, it was 29%. And for those who were already on dialysis, it was 31% only. So in 2003, commissioned the Institute for Health Improvement, and they planned this National Vascular Access Improvement Initiative, which was to promote the creation of AV fistula to 40% of prevalent patients on hemodialysis. A couple of years later, this was renamed to the Fistula First Breakthrough Initiative, and the emphasis here was more on AV fistula specifically, with the hope of increasing the rate of more than 50% of patients undergoing dialysis to get a fistula. And this was, it was done pretty well, and it was tied to certain financial compensation for the dialysis units, which led to 2009, the goal was increased to 66% or more. In 2015, there was a focus shift, and this initiative was transformed into Fistula First, Catheter Last. And the goal was to have more than 80%, actually more than 80% of the patients were starting with a perm cath. So the goal of this intervention was to have more and more patients have a definitive access with less focus on specifically a fistula, but rather on a permanent access. So whether it's a PD catheter for those who are planned to start PD, or AV fistula or graft for those who are planning to start hemodialysis. So our baseline for both hospitals from January 2015 through December 2015, 80% of patients had their access placed within 30 days of RRT initiation, which was consistent with the CMS goal already. So we hope to improve by reaching a target of 85% or more, and that with an aim to reduce the duration of catheter use in our patients. So this was the intervention was a multidisciplinary intervention. Every time there was a patient who was being started on hemodialysis at the hospital, we automatically consulted the vascular surgeons who were also a very important partner in this project. We explained right away to the patients the importance of obtaining permanent access, and we obtained automatically vein mapping for the surgeons even before calling them. So this way we consulted the surgeons, and then they had the data that they needed right away. And we looked at how many patients had permanent access placed within 30 days. So as you see, we did pretty well. The numbers are not so great in the sense that the census is not so big, since most of our patients are started in the outpatient setting, and they try to not let them fall into dialysis. So in July and in August, we did not reach our target, but that was really related to the exclusion criteria that we had in the study. We did not include, for example, patients who were being transitioned to PD initially. Also, those who had complex cardiac issues, we eliminated them from our population, since those needed a cardiac cath, some needed coronary interventions. And for that reason, we excluded them since it was a little unrealistic to have them go to the OR necessarily within 30 days. And by doing so, we actually did very good on this project. And I give also credits to the surgeons who were our major partners. So we learned from this project the importance of multidisciplinary interventions, and also even though we are consultants, ownership of the patients was still important by ordering proactively certain tests to facilitate these procedures. The third project I'm going to talk about is also feeds into the same idea, but it's about educating patients with advanced chronic kidney disease about the different modalities for renal replacement therapy, and planning also for the next step in their disease course. The population here was the Fellows Clinic patients. So we looked at all those who had CKD stage 4 and 5. CKD 4 usually is 30 milliliter per minute of a GFR or less, but we looked at where it's indicated to start planning, and it's 20 milliliters or less. So why did we do this? Because those who were educated, studies have shown in 2005, 2004 from countries that those who were educated had lower hospitalization rate, and their mortality was lower in the first 90 days after initiating hemodialysis. And dialysis education was also associated with a planned start in a significant portion of patients who were educated, as opposed to those who fell into dialysis, meaning they ended up in the hospital uremic or with complication of end-stage renal disease requiring them to start dialysis without having an access already placed or prepared. And this also, the education allowed for consideration of no dialysis options in patients who were very frail and had a very low life expectancy because of other comorbidities. Our baseline was not so great. The Fellows Clinic population is a difficult population, and a lot of them would not really follow up regularly. So we noticed that only 30% of our patients are being educated appropriately, and the documentation of such was present in the follow-up notes. So our goal was to improve the education and the documentation of this education of the patients in our population to 65% over 1 year of time. We provided educational material regarding the different modalities for renal replacement therapy. There is the National Kidney Foundation that has very good brochures that explain each modality, and the fellow would spend some time also with the patients explaining what exactly it means. We also had a preemptive referral for transplant and PD nurses to educate the patients about the option of peritoneal dialysis. And the intervention exactly was a standardized documentation in the EMR. So part of the, again, past medical history, there was past surgical, and also we added a section where it says education of CKD treatment options, whether it was documented or not, and what the patients are opting for. There was also a weekly email sent by our coordinator to the fellows and to the faculty staff. And we had good results as well. Sometimes we were very close to the baseline, to the target, and we noticed that actually printing out we did a small cycle over 2 clinic sessions, and we noticed that printing the material as opposed to just having it on the computer and opening the brochures helped tremendously improve. And most patients were educated in multiple sessions. Again, we had a little dip in July and August, but I think overall we did pretty well. So I'm going to touch now upon 2 projects that we are currently developing. The first one is about improving the administration of EPOGEN, or erythropoietin stimulating agents, in patients who are hospitalized. If you look at this data, it's a little scattered, but it varies a lot tremendously between different floors. So some floors do very well, and some floors do terribly. So these patients would have an order for EPOGEN either Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday. Historically, this medication used to be given intravenously in the dialysis unit by the dialysis nurses. And then a few years back, there was a study showing that subcutaneous EPO is equally and even more effective than intravenous EPOGEN, and reduced the amount of units required. And there was a transition from giving the EPOGEN during the hemodialysis treatments to intravenously to a subcutaneous administration by the nurses on the floor. So there are multiple reasons why these doses are being missed. For example, on 7 West, that hosts a lot of our patients, out of 25 or 26 doses ordered in the space of a month between March 10th and April 10th, 2018, none of the doses were missed. Whereas if you look, for example, at another floor, 6 West, out of 16 or 17 doses, there were about 4 missed, making a percentage of about 25% of the doses being missed, which is tremendous. Imagine an antibiotic being missed by 25%. I don't think anybody would be happy about that. So the fact that these EPOGEN doses are being missed are causing the anemia control that is strictly regulated by CMS in the outpatient unit to drop, and patients are being discharged to their dialysis unit anemic. This might cause also readmissions for blood transfusions or other anemia-related complications. So on average, in this month, between March 10th and April 10th, the missed doses was about 20%. The total ordered doses of EPOGEN were 143 doses. Epic is being great that we are able to fairly easily get this data. I did this data in maybe 10 minutes. I was able to get the statistics, which was completely different from previously. So I looked at the documentation of why these doses were being held. So some of them, for example, other was a common one, a recurring reason of why the EPOGEN was being held, or contraindicated, which also is interesting in my opinion. Another one that makes a lot of sense to me was patient not due for dialysis today. And again, this goes back to the fact that this medication was historically given during the dialysis treatment. So the nurses on the floor were actually making a medical decision for a reason that I still haven't really explored well enough to understand the rationale why these doses are being held by the nurses. And so we're building a team with Stephen Levy from the pharmacy, and then also one of the nursing educators at West, as well as the IT team from Epic and the physicians from the nephrology division. And we're planning a PDSA cycle very soon to look at just updating a comment section in the order on Epic, where it says that we have to, or we have to be, it has to be given regardless of the dialysis day schedule on the floor. And if the patient would be off the floor, it has to be given when they are back. And we will see how this will help us hopefully solve this problem. And lastly, this is going to be the capstone project for my fellowship. So it will be about improving the first shift dialysis start time, and it will be only at the Mount Sinai St. Luke's site, inpatient dialysis unit. The goal of this is to improve the timeliness of care, and we hope that this would improve the patient experience because they would get dialysis early on. And in another also benefit would be to improve the efficiency of care. There is a whiplash effect. Once the dialysis, the first shift is starting late, this would push all the next shifts also later, and that would lead to the nurses staying later, which also causes certain unnecessary expenses, but staff burnout for the nurses. And we hope that by dialyzing the patients early on during the day, we would be able to discharge those who need to be discharged on time. So that would potentially also improve or decrease the length of stay of the patients and improve the timely hospital discharge. We did an analysis for February 2018, and the average days where the first shift was started in a delayed time was 78%. On most days we see delays. On some days the dialysis are pretty slow, and it's based on a really we get 1 or 2 patients, so we did not include these patients who can be started at any time during the day for certain indications. The average delay every day was about 30 minutes. So we set the start date, the start time at 9 a.m. That's when the nurses come, and then there's a process that I don't think I'm going to go through it in details, but we mapped out the process of how this procedure really goes. It starts on the day before, and there are multiple steps. For example, first of all, the renal physicians would have to run the list with the nurses. The nurses would prepare a list and give it to the clerk. The clerk would fax this form to all the floors where the patients are, and we'll place orders the night before for transportation in the morning. On the day of dialysis, the kitchen has to deliver the trays for the patients who are on dialysis earlier than also. That's another step. And the trays have to be delivered actually to the bedside. A lot of times they are on the floor and they are just sitting there, and the patients don't have their breakfast and they refuse, for example, to come because they don't want to be dialyzed before eating. And the nurses on the floor have to prepare these patients as well to hand them out to the transporter when the transporter comes. In the meantime, the dialysis assistant would be preparing early on during the day of the dialysis the machines. The nurses come at 9. There's a last step in the machine preparation that the nurse has to supervise the assistant before being able to receive the patients from the transporters who are transporting them from the floors. And then theoretically, the dialysis start time should be at the latest at 9:30. So right now, we're still in the step of understanding where are the major pitfalls that we need to improve on. Some of them could be related to the physicians, also related to the nurses, whether it's dialysis nurses who could forget patients or come not really on time. The physicians, for example, would not have obtained consent in an appropriate time, and that would lead to delays. Also, a major problem is transportation delays. The start time at 9 typically falls into the start time of everything else in the hospital. So the limited resources could be a problem as well, because these transporters are taking patients to the echo lab, to the endoscopy suite, etc. And that will cause a bottleneck in the transportation system. Equipment failure is a rare occurrence. Patient preference who do not want to be dialyzed in the morning is another problem. So we are building a team. The hospital leadership is also very interested in this project because of the potential of decreasing the length of stay by discharging patients before noon. We're still trying to understand which one is the major issue that is contributing and that we need to target first. The team is being built right now, and we will be tackling probably first starting by potentially a change in the start time of the dialysis. Instead of starting at 9 or 9:30, we might be starting at 7. So this is still work in progress. That's it. Thank you.